With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMicelle technology.
Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode.
In 1972, Matt Christopher wrote his most famous of his 140 books, The Kid Who Only Hit Homes. It was not only his best-selling title, but it also was his personal favorite and his dream to turn it into a film one day. Through the efforts of his sons, Dale and Dwayne, and producer Wayne Chesler, that dream finally happened in 2020. Oh, and that's me, Alex Montero. I played Sylvester Codman, the kid who only hit homes. During the production, I would ask Dale and Dwayne, where did it all begin? Why did the ghosts of Babe Ruth come back and teach Sylvester how to hit homes? Well, it was a secret till now, and my mom asked me to finally share it.
Hello and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gelb, the host of the documentary Open Your Eyes. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. Also, please leave comments. Great news, you can now watch our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. And please share your thoughts by emailing me at drkerrygelb@gmail.com and visit my website at drkerrygelb.com. There are close to 300 systemic disease states that can manifest in the eye. New technology in eye care allows the optometrist to examine the body's tiniest blood vessels and nerve tissue. This allows for the earliest detection of systemic disease such as prediabetes, diabetes, hypertension, cardiovascular disease, and even possibly Alzheimer's. Using the eye to detect patients early in the disease spectrum can prevent or delay the development of chronic disease and early death. Today's guest, retina specialist, researcher, and inventor, Dr. Steven Sinclair, MD. Dr. Sinclair graduated from Harvard Medical School and has trained ophthalmic surgeons worldwide. His research includes the development of many digital devices, including the laser doppler, used to measure retinal blood flow. Dr. Sinclair is an expert in subclinical eye disease and has connected the dots between subclinical eye disease and early detection of systemic and ocular disease. Dr. Sinclair, thank you for joining me today.
Thanks, Kerry. It's a pleasure being here with you.
You know, we're kind of like kindred spirits. We both have an extreme interest in finding systemic disease early by using the eye as a biomarker. Tell me why, tell the audience why the eye is such a good biomarker to find systemic disease, not only eye disease, but systemic disease.
Well, this is because, Kerry, the retina, which can be imaged and viewed directly, has the microvascular and the neuronal integrated concepts that are easy to image and to assess, and which are the window to similar processes of the microvascular and the neuronal degeneration going on in the brain, as you said, in Alzheimer's or diabetes or even we're realizing glaucoma is associated with significant neurologic abnormalities. And as with diabetes, with peripheral neuropathy, and also we're now realizing that that retina is the window to the cardiac malfunctions that are going on in the neural transmission through the heart, as well as the myocyte contraction of that heart muscle, and in the kidney. So we're realizing that the retina offers the real opportunity to image these lesions early and to assess the treatment effects.
You know, we have blood vessels in the brain and they go all the way through the body and all the way to the toes, but we could see the ones in the eye. It's actually incredible. Tell me, are the eye blood vessels any different than the toe blood vessels or the brain blood vessels or the heart blood vessels?
Well, they are, because that retina in the back of your eye is focusing, that it is focused with intense light. So just like when you, my son, with your skin can get sunburn when you go out into the sun, think of that retina as being intensely focused with light, so that that retina has to be able to prevent damage from that light. So there are intense mechanisms for controlling blood flow, what we call autoregulation of that blood flow in the retina, as well as the choriocapillaris behind the retina to keep it cool and well supplied with the nutrients that are required for those rods and cones to be able to detect the images. So these blood vessels and the reactions with the neural meshwork that holds the retina and those neurons within it all have to be able to function well and to protect against the, let's call it, injury of that bright light.
You know, early in my career, we would use an ophthalmoscope and we could see the retinal blood vessels around 150 microns. Now there's technology, we could see 8 microns or 10 microns. And that really helps us to be able to find disease much earlier than we used to. So someone would be diabetic, we would know they were diabetic, and then we would see bleeding and refer to somebody like you, a retina specialist. But now we could pick up these vascular changes so early that the eye doctor now is the first in many times to diagnose a systemic disease. And we are using the eye as this incredible biomarker. So can you just talk a little bit about the evolution of technology in eye care and how we've gone from 150 microns back when I think Helmholtz developed the ophthalmoscope to where we are now at 8 microns?
All right. Well, what we have to understand, again, as I said, that those neurons, okay, you have to understand that the photoreceptors, the rods and cones, are in the outer layer of the retina. And they transmit the pixelated image into the middle nuclear layer of that retina, which senses the edges of that image and the textures and the orientations and the motion. But remember, it has to detect the wavelengths as well so that you can have color vision. And it has to detect it at all different light levels. So those then middle nuclear layer transmit those preliminary images to the ganglion cell, which then transmits it to the brain. So if we are interested not only in detecting the early abnormalities of vision problems, but also, which now the retina has become the leading cause worldwide of, let's call it, mild, moderate, and severe vision loss. So while the industry has been focused on the focus of the eye for nearly 300 years, it's really that retina that we have to image those lesions. So we can detect not only the effect on the vision, it's the primary focus of the eye professor, the optometrist and the ophthalmologist, but we have to be able to visualize, to image those lesions, not just in the blood vessels that you intimated, but primarily in the neurons as well, throughout all those layers, we have to be able to detect those early in the disease course, because what we've relied on for the past 50, 75 years is the doc looking in and seeing lesions in that retina. But what does that doctor see, whether it's the general physician managing the patient or the diabetologist seeing the diabetic patient or the neurologist seeing the Alzheimer's patient? What they primarily see are, oh yeah, there's some blood vessels back there, but they predominantly are looking for hemorrhages. But we're now realizing that we only see hemorrhages late in the game. And that we're now realizing that what we used to think of as, oh, well, the loss of vision and the neuronal degeneration of all of these, glaucoma, macular degeneration, diabetic retinopathy, Alzheimer's, we used to think of these as being caused by vascular diseases, but we're now realizing that actually those lesions in the neurons start developing even before the earliest microvascular changes.
And I've seen in your writings that diabetes, glaucoma, Alzheimer's, and macular degeneration have the same pathophysiology throughout the entire disease. Can you explain that in simply terms because we have doctors watching, but we also have lay people watching.
All right. Okay, so yes, I will try to keep this as flat as I can. All right, but what we have to realize is if these lesions are developing in the neurons, in these 3 layers of neurons early in the game, just like they are in the brain and elsewhere in the body that we will discuss, those lesions we're now realizing are due to what we call oxidative stress. So we're realizing that glucose and oxygen are the primary metabolic factors for developing the energy, ATP, that you need to generate the signals from those neurons to travel back through the neuronal axons to the brain. The generation of that produces glutamate, which is a toxic effect. So that glutamate has to be metabolized, let's call it that, and gotten rid of, and it generates oxygen-free radicals. The oxygen-free radicals, including nitric oxide, are produced by the neurons that in order to generate the ATP, but they are in themselves toxic and they diffuse out. So what we're realizing now is that this oxidative stress caused by this metabolic consumption of oxygen and generation of glutamate from the glucose, all of that's going on, predominantly started in the mitochondria of your neurons, has to be modified and controlled. And that's controlled by the encasement. So all the neurons in your eye are encased in a sheath, are encased in a matrix of glial cells. Mueller cells in the outer retina, astrocytes in the inner retina. These encase and help to modify that whole oxidative stress. The problem here is that when you have high glucose levels, that creates more oxygen-free radicals. But what's going on systemically, we're now realizing, is that diabetes is not just a blood sugar abnormality. Your high blood sugar is due to a number of factors. A major factor in the overwhelming type 2 diabetes, that's 85%, is caused by an autoimmune disorder, meaning insulin resistance caused by inflammation in your core fat. And that insulin resistance and inflammation throughout the body is causing inflammation that injures the pancreas, reduces the insulin production, injures your kidneys, injures your liver, injures your retina, injures your brain, injures your peripheral neuropathy. So it's initial oxidative stress combined with this systemic inflammation that's causing these problems.
And you mentioned the core fat. We're talking about the bad fat, visceral fat, or the deep subcutaneous fats. That's almost an organ in itself that's producing inflammation, that's causing damage.
All of this is. So what we have to realize is, yes, diabetes is a systemic disease, but we've got to realize it's more than just managing the blood sugar. And what we're now realizing is because of this inflammation that's going on and you're consuming different levels of glucose daily, is it's not just the hemoglobin A1C, which is your average blood sugar, but it's the variation, the hyperglycemia that creates these oxygen-free radicals. But then it's the hypoglycemia reactions that create aggravate the ischemia in the retina. So what we're realizing is the retinal blood vessels that get these signals from the glia, from the Mueller cells, these retinal blood vessels, and we're now starting to realize the choroids involved in this as well, those are not regulated appropriately for the amount of oxygen levels that are coming in to metabolize these things. Okay, you follow me? All right, so what we're saying here is that we're having periods of ischemia when the blood sugar drops and the blood vessels don't dilate because the microvessels are either injured by the inflammation or by the oxidative abnormalities. The oxygen-free radicals are modify those signals produced by the glia that allow you to control your blood vessels in the retina. They are not reacting right. So you get ischemia and then elevated blood flow and blood pressures in those blood vessels.
So when we get the ischemia, one of the first cells to die off are the pericytes. And the pericytes have many functions. And one of the functions is to protect the retinal blood vessels, remodeling, regulating blood flow, wrapping around the endothelium throughout the body. And so we start losing the pericytes if the blood pressure goes up or the blood sugar goes up too much. And that's what starts to cascade. Am I correct on that?
You are correct. Yeah, the endothelium actually we're realizing even has an earlier in the junctions between the endothelium. They are separating and so allowing a little bit of flow. This, remember, the retina has to remain clear. Those cells in the retina have to be clear so the light is transmitted all the way down to the photoreceptors. So the light is actually transmitted through those glial, so that they're focused on the photoreceptors. So if there's any leakage of the endothelium, and you're right, it's controlled by the pericytes, but the pericytes also are helping to control the size of the lumen. And so when the pericytes are affected by these signals of inflammation from the glia, what happens is they start to swell, so it constricts the blood vessels, and they secrete what are called VCAMs and ICAMs, which are cells that attract the endothelium, attracts leukocytes to help with the inflammation, but the leukocytes plug the blood vessels, so we start getting microvascular occlusions.
Before you mention nitric oxide, we know that nitric oxide is very important to the blood vessels. But if it's too much or too little, there's a problem. It has to be homeostasis. So if you could, there's a lot of people out there listening, they take nitric oxide supplements that increase nitric oxide. They want to eat foods such as watermelon to increase nitric oxide. But you said before that nitric oxide, maybe if it's too much, could be a problem.
Exactly. Yeah. So this whole task is switching to antioxidants. In other words, if you have this oxidative stress, we really need to, as you said, control that. And that's with antioxidants. Now, again, with the natural foods and stuff, it's hard to know when I eat this or I take the antioxidants by mouth, my gut is going to alter them to some degree. And how much of those antioxidants get into the blood to control that nitric oxide, and how much, and the blood vessel abnormalities, but how much of those antioxidants get through the blood retinal barrier and blood-brain barrier to affect that oxidative stress going on in the neurons. So we really need to evaluate these much better through ways of imaging the retina so that we can actually detect these antioxidants and resultant inflammatory effects. So the retina, again, offers the window an opportunity to do this.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
So I want to start off with the pathophysiology, kind of geeking out, but now let's talk a little bit more clinically and how what we see in the retina and how it could, if someone has high blood pressure or they have cognitive problems or they have cardiovascular hypertension, how this kidney problems, this could affect the retina. So I know you have some slides. So if you could pull up your slides and we could go through some of them to show how systemic disease can be seen in the retina, often way before it's picked up by your internist, because I want you to speak about the different size of the blood vessels, the size of the blood vessels in the retina the capillaries compared to the size of the blood vessels in the heart, and why disease will happen in the retina earlier because the capillaries are so small, as Dr. De Silva mentioned in our film.
Yes, and again, we'll just try to keep it as flat as we can, because so what I'll try to point out is the primary focus for the past 30, 40 years has been on large vessel disease, major infarcts in the heart, in the retina, in the brain. But now we're realizing that the microvascular disease caused by this oxidative stress and the abnormalities of blood flow in the retina that occur also in the brain, those things, as you said, are due to the fine little precapillary arterioles and how well they can react, and the capillaries themselves and how well they are perfused, or if there are nicks and injuries to these. And so I'm going to try to show in these images what we have concentrated on in the past and where we really have to go to understand this microvascular disease that's occurring in those diseases that you just talked about. Okay, if you can give me permission to share my screen, I'll do that.
Good. And everybody is very fascinated about this because they go to the eye doctor and they think, oh, well, I'm just going for glasses or contacts. They don't realize the whole medical side of what could be found by having an eye exam.
Right. Okay. Can you see my screen?
I see it perfect.
Okay. Here we go. Okay. So this is just a real quick summary of how the increased excessive fuel, the glucose and the lipids that are circulating affect all of these different, creating the insulin resistance in the fat, and how that alters our environment and creates inflammation throughout all of the cells, and how they create the specific images and problems that we can see in retinopathy, but are also occurring in the kidney and the brain, and how they cause dysfunction of vision, but also those cells. And again, we have to not lose focus that the pancreas is affected by this inflammation, creating reduced insulin secretion.
Before we change that slide, if you could go back for a second, I do want to ask you.
Sure, yeah, you keep me focused.
So insulin resistance, for the people that don't know what that is, if you could explain that.
Okay. Again, what's happening here is in the fat, you with diabetes, you are having an inflammation that is going on that is actually creating antibodies to insulin. So that is then attaching to the insulin molecules so that they are ineffective. And so therefore there is this what's called insulin resistance. Remember, the insulin helps to get the sugar modified within your cells, whether it's in the retinal neurons, brain neurons, or elsewhere.
Yeah, so if we're trying to get the insulin into the muscles and there's a problem with receptor, and the receptor is not understanding that it needs to get the insulin, the pancreas is going to start making more insulin, and
Fine.
and it's resistant to getting into the muscles, the liver, or any of the cells it's supposed to, and then the increase in insulin is floating around the body, and many times the insulin will be high up to 20 years before blood sugar goes high, and insulin is just as damaging to the blood vessels as blood sugar. So I think that's important. And, you know, inflammation is the core component to chronic disease. So when the body's inflamed, we're at greater risk of having damage anywhere in the body.
Exactly. Again, I keep saying, and we've written this in a number of reviews, which if they write to you, we're happy to supply them, that we have to rethink diabetes as an autoimmune inflammatory disorder.
And if we can pick up diabetes early, all the things that diabetes causes, like you showed, cardiovascular disease, cancer, the kidney disease, all, you know, from head to toe, the Alzheimer's, the type, now they're calling it type 3 Alzheimer's diabetes. So if we could find that early, we could prevent a lot of diseases. So I'll go with this next slide.
All right. Now, I put this in, and I apologize, it's just really complicated, and it's upside down. But this is from an article by Dr. Wang, who basically looked at slides of individuals, of retinas, of individuals with Alzheimer's. And so they were looking to see if they could detect amyloid beta plaques, which are recognized in the brain to cause the or to be associated with the Alzheimer's. Does it occur in the retina? But I'm showing you just so the choroid here is usually presented at the bottom, but here's the choroid. So the light is focused from the bottom through the nerve fiber layer. So this is the nerves going back to the brain. And so these are the large arteries and veins that we will see in the images in that nerve fiber layer. And these are the astrocytes that are around the blood vessels. So they're on the outside of the pericytes. So those are the equivalent of Mueller cells. There's the ganglion cells that are controlling the blood vessels of those smaller arterioles, okay? Now, these are the Mueller cells that span all the way to the external limiting membrane through the ganglion cell layer. So these are the ganglion cells that transmit to the brain, and they get the signals from the middle nuclear layer, which is in here, okay?
And this is the middle nuclear of the retina.
This is the middle nuclear layer of the retina, the bipolar cells. So, well, I'm sorry. Let's start with the photoreceptors on the outer. So here are the rods and cones. The cones are the cone-shaped, and the rods are wrong-shaped with the long fibers that are embedded in the epithelium, the pigment epithelium here. And this is supplied by the high blood flow of the choroid. And so all the way from the soma of the photoreceptors all the way out to the ganglion cells, this meshwork of glia, of Mueller, are encasing around them and controlling their metabolism so that they can detect the images and transmit through the bipolar cells and the amacrine cells to the ganglion cells and out to the brain. Okay?
And before you change the slide, in diabetes, what part of the retina are we going to see the hemorrhages of when we see this big chart of the retina? Where are we going to see the hemorrhages in diabetes? Where are we going to see the hemorrhages or changes in macular degeneration? Where are we going to see changes in Alzheimer's? Where are we going to see changes in hypertension? Before we show the real pictures in this cartoon, if you could just give us a preview so to make it clear when we go to the other slides.
Again, I apologize for this image being upside down, but it's because this fellow was looking at Alzheimer's. And what he's saying is Alzheimer's amyloid is detected both here and we're going to see some drusen-like material of amyloid deposited there, but they also saw it in the outer portion of the rods and cones, I'm sorry, the inner portion of the rods and cones, and all the way through. So all of these layers have been shown to accumulate the amyloid. That was the one question you asked that's associated with Alzheimer's. Number two, you said, where do we usually see hemorrhages that are occurring with diabetic retinopathy? And that's predominantly from these blood vessels in between the ganglion cell layer and the middle nuclear layer, and between the middle nuclear layer and the photoreceptor layer. So the hemorrhages are occurring in here and in here.
Beautiful.
Okay. All right. Now, you're asking about macular degeneration. Where does that occur? Well, we're realizing that that's due, and again, these are all due now in the past 5 years or so. We're realizing that the same biomedical abnormalities that are occurring in the outer retina due to the light that's penetrated that is injuring those pigmented cells and the photoreceptors, so they're not metabolizing those rod and cone outer segments right, and creating these lesions that are occurring in the lesion close to the pigment epithelium and destroying this layer. In the Alzheimer's, more so, we're seeing some in here, but predominantly in the middle nuclear layers. And in the diabetic, we're going to be seeing a lot in this inner retina. But we're realizing that the middle nuclear layer is affected too, because of both of these layers in the inner retina that are not undergoing the normal autoregulation are creating a lot of these lesions in the nuclear cells themselves, okay? All right. And then lastly, in glaucoma, one thing that's always bothered me is, why does the glaucoma seem to preferentially affect the ganglion cells way up here on the surface? So we'll sort of touch on that as we go through all of these diseases. But again, in the last 5 years, we're realizing this oxidative stress and the inflammation that's occurring in the neurons and in the Mueller cells around them these metabolic processes are occurring throughout all of these disease processes. Okay, that's what we've got to think about.
Great.
Okay, I'm sorry I took so long on that.
Oh, that was fantastic. Thank you.
Why am I not? Okay, all right. Now, this is just an additional slide to show that the blood vessels, as you said, are encased with the endothelium, and in the retina, like the brain, they solidify between the cells along those blood vessels to create the blood-brain barrier and blood-retinal barrier to allow only the metabolites going in, but also, how does that glutamate and those other toxic byproducts, the oxygen and nitrogen, the oxygen-free radicals, how do we get rid of those or metabolize them so they don't create toxic products? And when they don't create the toxic products, when they don't neutralize those things, the astrocytes and the Mueller cells activate microglia. So these are stationary, inactive white blood cells within the retina. They're just sitting there helping to maintain the normal low-grade inflammation to keep this retina clear, healthy, and observing and transmitting those image signals back to the brain. Okay? I just put this in there just to do it. Now, the reason that I put in this is because what we have to realize is that the oxidative stress, predominantly visualized over here, that all the cells, the neurons, the glial cells, and all of the cells within the retina are basically attacked by a huge amount of glucose, free fatty acids, and they generate all kinds of products that we're now realizing, and again, with insulin resistance that prevents the insulin from helping to metabolize that glucose appropriately, and all the inflammation that is systemic is now impinging on these cells. It's a complex processes that are going on. So we cannot no longer think of this as signal processes that we can attack with one treatment. We got to think about combinations of treatment. And this is a major aspect that I am trying to, and multiple people now are trying to convey in terms of understanding these diseases and treating them, not just in the retina, but in the brain, the kidney, pancreas, etc. Okay? So within the mitochondria, now the mitochondria are within the soma, they start the signals in the photoreceptors and middle nuclear and ganglion cell layers. But then the signals have to be conducted through the axons to the brain. The axons and dendrites within the retina are unique because that inner retina has to stay clear and transmit that focused light to the photoreceptors. So therefore, these axons don't have myelin around the axons like the rest of the body does. So therefore, they need axons. The axons need mitochondria all up and down those axons to help transmit the metabolites up and down those axons and to conduct those signals. So these mitochondria that are having these abnormalities of, again, the glycolysis, etc., are creating all kinds of reactive oxygen species and all kinds of things that we call the mitochondrial dysfunction. It's going on not just in the soma, but also in the axons through the nerve fiber layer, all the way out to the lamina curbosa in the back of the eye.
This is a great slide because it shows that you want to try to prevent yourself from becoming inflamed and have high insulin and high blood sugar. You want to avoid things that cause that, such as smoking and metabolic syndrome with the big belly, eating a lot of high fructose corn syrup, like things with products with sugar, a lot of grains that increase blood sugar or trans fats. So, and that you want to eat healthy foods like wild salmon, sardines, mackerel, good things with omega-3s, and a lot of fruits and organic fruits and vegetables, and drink clean water, and take certain supplements that we're going to talk about in a little while. So we want to be on an anti-inflammatory type diet. So thank you for showing that. That's a great
slide. It's just very quickly, the antioxidants that have had the most studies have been alpha lipoic acid, benfotiamine, and now more newer on the list of the crosins, crocetin, etc. But it's just important to recognize that these cause all kinds of gene abnormalities and all kinds of inflammatory secondary effects that are to some degree. One little effect here is by the GLP-1 receptor agonists that are now being promoted. But what I'm trying to show here is that it requires a combination of treatments to really produce the effects that we want. Okay. All right. I'm going to sort of skip through this because it's just showing that all of these, the neurons, the macroglia, the microglia, and the blood vessels and the endothelium and parasites, they're all interacting. And that's what I tried to show in this slide. Okay, so this is a picture of a retina with moderate diabetic retinopathy. So this is what the doc sees most often when the patient first presents with vision abnormalities. This is the problem, is that the medical doc, we don't have adequate imaging going on in the general diabetic clinics or the Alzheimer clinics or the, we need imaging that will detect it earlier than when the patient first presents with symptoms, because for reasons I'll explain, the symptoms don't occur in your daily life often until late.
Dr. Sinclair, if you could go back, for the people that aren't doctors that are looking, this will point out what we're seeing here between the hemorrhaging and the heart exudates and the changes of the blood vessel caliber.
Yeah. Look at these. Look at the sclerotic changes of the veins here, and look at these arteries and how they are changed. You know, they're just thinned out and they're just grossly. And you get nerve fiber layer abnormalities that are going on here. And as you said, exudates. So there are all kinds of things that are going on here that are affecting that retinal.
And they exudate the leakage of lipids. And you can see all the hemorrhages in the eye.
Right. Okay. So let's just say that you're a general medical doc and you're trying to look through maybe an undilated pupil and stuff. When the doc is looking through that older person's lens that has a little bit of cataract and stuff, he doesn't see much. So you're saying, well, their optic nerve looks pretty good and the artery, they look pretty good, but he doesn't recognize, because mainly, again, what you see are, because your vision is predominantly red-green maximized with less input from your blue cones. So you don't see so much. You say, well, maybe there's a hemorrhage down here. Okay, but if we can subtract out some of that blue light, look at the blood vessel abnormalities that you're seeing in this image. So if you could screen with a better imaging device and alter the combination of those colors, you can start to pick up those abnormalities. So look at the large blood vessel sheathing here, and look at the microaneurysms that you're starting to see here. But you're saying, well, where's that hemorrhage that I thought I saw? Okay. But if you now start to look with single wavelengths, we can start with the innermost retina and lower wavelengths. And this allows us to really start to see abnormalities of the blood vessels and the nerve fiber layer much better. As we go to the deeper wavelengths that penetrate deeper into the retina, we can start to see all different kinds of lesions in here. And we can still see some of the microaneurysms and the capillary abnormalities, the microvascular abnormalities. Okay, and we can go, sorry, we're going to the very deep.
The vascular changes inside the blood vessel that shows atherosclerotic changes.
Yes.
Show that.
Yeah. See some of these. Look at some of these things. See? Look at these things that you're seeing in the large blood vessels. But again, the microvascular control is controlled by the smaller blood vessels. So
those white streaks within the blood vessels, we could consider those atherosclerotic changes.
Yes, sir. Yeah. Okay, but look here at the deeper. So we're seeing microaneurysms and dark things, but we're seeing a lot of dark, smudgy lesions here that are in the outer retina that we never realized before, but we're now seeing with the longer wavelength red monofocal wavelength and infrared images. And we're now starting to see abnormalities of the choriocapillaris that we didn't realize before. So I'm just showing here a normal image obtained with the OCT. And you can see here the different layers. So here is the choroid, and look at this fine choriocapillaris that you can see in here. And here's Brooks membrane with the pigment epithelium. Look at how thin the pigment epithelium here is. Now, here is the rod and cone layer. And remember, there are no rods in the center of the vision, only cones. So look at how the cones are thickened up here a little bit, okay? And how they're producing the outer plexiform connections to this middle nuclear layer right in here. I'm just pointing this out because I'm going to show now, subsequently, abnormalities of all of these layers as we go on. Finally, they connect through the inner plexiform dendrites to the ganglion cell layer. And notice how the ganglion cell layer is thinned way out here. So we allow the focus to those cones right in the center to be beautiful. These are the parvocellular cones that see the detail in predominantly the red and green wavelengths.
And for people that's not familiar, this is an OCT image. And if you could just explain what an OCT is.
Okay, I'm sorry. What we're doing is we're taking a laser and we are scanning through the retina very rapidly so that we can get all three of these layers, and we can either do it axially around the fovea or we can do it horizontally through the retina at different positions. Okay? All right. So here's what we would commonly see in diabetics. So what we see here are hemorrhages and exudates in the outer retina in that plexiform layer. Look at this here. So these are associated more so in this eye with the outer retinal, the inner retinal capillary plexus that's producing the blood vessels to the ganglion cells and to the middle nuclear layer. So these are on the outer side of that middle nuclear layer. But look at how what's not commonly thought about is, how is my middle nuclear layer thickened? And okay, is this a little bit of edema that we can see here as collections of hollow cysts of clear fluid here? Okay, but look here at, so here's some cystic collections of fluid in here. But look at how the middle nuclear layer is thickened, all in here and here. Okay, so there's all kinds of cellular neuronal abnormalities that are going on besides just the collection of these hemorrhages and exudates that we've paid attention to and the leakages of fluid, which has been the predominant focus for the past 10, 20 years that these OCTs have been available. Okay? All right. Here again, you see exudates and hemorrhages, exudates, I think, because these are focal and small. And okay, and here's a pretty nice thin middle nuclear layer here. But look here at this edema and swelling that's going on in here and over in here. Okay, now these exudates are creating shadows, so that's what you're seeing here. But what we're now realizing are what are called drills and drolls. The drill is the diffuse, disorganized inner retinal layers. Okay, so here you see, this looks pretty normal here. But as we come over here, we see diffuse thickening of that middle nuclear layer and ganglion cell layer with pinpoint collections of something that's going on, along with the cystic collections in this diabetic. Okay, so the drill is disorganized. So we don't know, is it totally infarcted? Or is it some sort of swelling of those Mueller cells and neurons in the apoptosis process? But it's a progressive degenerative. So even though we can give medications to try to treat the edema, we're now realizing that these aspects really limit any kind of vision improvement with the current treatments that are now projected predominantly from injections. When we look at en face images, we see a little bit of paleness, but sometimes they can be white nerve fiber layer infarcts, but sometimes they can be just a little bit of pallor of the en face image that we previously recognized with the old fundus cameras. Okay?
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.